Welcome to the Next Society's webinar. We are going to be diving into the NEST trial results, which we're really excited about. We have a great panel of experts here with you today. We are dedicating today's webinar to Seth, and Seth's mother is here today. She'll be sharing her story, her family story with us. As you can see, Seth was born prematurely. He was diagnosed with NEC and now lives with long-term complications of the disease. I want to say thank you to Engage, Grow, Thrive for providing our webinar with continuing education. And really, thank you all so much for being here. I'm going to advance to the next slide so we can get started. We've got a lot to cover today. So if anyone is just getting to know the NEC Society, welcome. Thank you for being here. The NEC Society is a 501c3 nonprofit organization that's dedicated to building a world without NEC. We bring together patient families, clinicians, and other diverse stakeholders to advance NEC research, education, and advocacy. These photos were taken before the pandemic, as you can imagine, at the 2019 NEC Symposium at the University of Michigan. I wanted to quickly highlight that we have a running team that will be running the California International Marathon in just a few weeks. We are working to raise $10,000, and the funds will be used to advance our research priorities and our biorepository and to provide resources to patient families who have been affected by NEC. So if you feel inspired to give, you might consider every one of our miles is dedicated to a child that has been affected by necrotizing enterocolitis, and we'll be carrying these children's names with us during our run. So if you are inspired to give, there's a chance to do so. So we're going to start with a live poll question. If you go to the chat box, you should see a link. And if you click the link, you should be able to vote on this. Yay, it's working on this question. So have you attended one of our webinars before? And I was just told by my friend and colleague, Ravi, that this is the NEC Society's 12th webinar. So it's really exciting. I love seeing new people here. Thank you so much for joining for the first time. This is great. Give this a few more seconds. We're going to be using this live poll feature throughout the webinar, so you can save this link. I'm going to advance to the next slide. And we're going to get started with just a series of live poll questions before I hand it over to Cristal to share her story. So for families who have an infant that underwent surgery for NEC, did someone talk to you about the long-term outcomes or complications of necrotizing enterocolitis? And so this is one of the poll that's really designed for families. And I would say no. I know my son required surgery for NEC, and no one talked to me about the long-term outcomes of the disease. I'm going to advance to the next slide. And for clinicians who care for infants with surgical NEC, do you routinely discuss long-term outcomes with families? All right, I'm going to move to the next slide. Now, are you familiar with Bayesian analysis? I was not, and I had to look it up before I even created this slide and this question. All right, I'm going to advance to the next slide. So here is your panel of speakers for today. For anyone who I haven't had the pleasure of meeting, I'm Jennifer Canvasser. I'm the founder and the director of the NEC Society. I lost my beautiful son, Micah, to complications of the disease just before his first birthday. Then you're going to hear from Cristal. As I mentioned, Cristal's son, Seth, is a NEC survivor and lives with long-term complications. She's going to be sharing her story, and Cristal has long been a member of the NEC Society's leadership team. You'll also hear from Marty, who is a pediatric surgeon at Vanderbilt and who led the NEST trial. You hear from David Hackam on our panel. He's a pediatric surgeon at Johns Hopkins, and Toby Yanowitz, who's a neonatologist at Pittsburgh and involved in the NEC Society's PCORI work, and Ravi Patel, who is one of our scientific advisory council members and helps to lead a lot of our webinars and is a neonatologist at Emory. So that's your speakers for today. I'm going to advance to the next slide. Just a quick disclaimer that we are not providing medical advice, and everyone's views are independent from the NEC Society. And now I'm going to hand it over to Cristal. I'm going to stop sharing my slides, Cristal, and you can go for it.
Thank you, Jen. It's such a pleasure to be here with everyone today and getting to share a little bit about our story and Seth's story, and really just giving the family perspective. And we are so appreciative that Next Society has always included the families throughout the process. My son Seth was born at 29 weeks. We were currently, or at the time, we were living overseas in a little town of Cadiz, Spain, which is on the southern tip. So they do little things a little differently in the south of Spain than they do in the north of Spain. But he was born, I had severe preeclampsia, IUGR, HELP syndrome. So when he was born, he was unresponsive. After resuscitation, he was taken to the NICU, where he kind of fought for his life as I fought for mine, in a different part of the hospital. So, the language barriers, the lack of translators, socialized medicine, cultural differences, just the variations of medical care compared to what we're accustomed to here in the United States, was just kind of a short list of the challenges that we faced being foreigners in another country's NICU. Throughout Seth's NICU stay, he had IVH grade 3 and 4, ROP grade 3. He had 2 rounds of sepsis, fungal infections. Of course, he had surgical neck, and then everything that kind of comes in between that are associated with all of that. On day 6 of life, Seth's stomach started to distend and started to change color, and he wasn't able to tolerate food. There was no output, and so on day 7, the neonatologist came to my room and told us that a drain would be placed, and that we'd just kind of have to wait and see what happened next. In true Seth fashion, on day 8 at like 3 a.m, he ripped out his drain because had never done anything the easy way. And so a second drain was placed, and we just kind of continued observation. And so just a lot of waiting, not really knowing what was going on. They kind of threw around to different terms, but nothing. I mean, I think I heard NEC a couple times, whether that be due to just being lost in translation or us not hearing it, because it was rarely used. On day 10, it was decided, because he was just kind of deteriorating really fast, that the decision would be made to perform an emergency laparotomy. They brought us into the room and told us to say our goodbyes. They didn't expect him to make it, and gave us basically a 1% chance of survival. They flew in a surgeon from France. Surgery was carried out, and that was done in an open bed in the NICU. Shortly after, he went into renal failure. We just kind of had to sit and wait, and wait. Seth's body slowly fought back, and after that, contracted a fungal infection, and then with that became septic. And then again, we were asked to say our goodbyes. At this point, I was able to be down in the NICU. And so I was part of that, just a lot of waiting. He was getting stronger finally, and just very strong-willed. And then we had another round of sepsis and fungal infections. And again, we were waiting. And on day 52, we were able to bring him home. He was just over 3 pounds. Coming home was another story in itself. Our neonatologist, which was the only English-speaking neonatologist at the time, was also pregnant and had my exact due date. So we kind of went home, and then we were we're back and forth to the NICU there in Spain to have transfusions and to be monitored. When Seth came home, he had severe GERD, severe jaundice. And so it was just kind of a sit and wait and lots of doctor's appointments. And like I said, back and forth to the NICU there in Spain. And Seth is now 10, he'll be 11 in February. And now we're kind of jumping into a world of, the long-term effects of his prematurity and of NEC. He has autism, cerebral palsy, language delays, cognitive delays. This last year, we've really been dealing with a lot more of the mental health issues, behavioral issues, educational language. And so really just, it's a lot of wait and see. And I think we had always wondered if it was because of the language barriers that we weren't really informed of what was going to happen, or what we should expect, or what we could expect, and so, I think communication is key with families. And it wasn't just our language barrier. We see it far too often that families aren't informed of and educated and spoken with. And as you can see, there was a lot of waiting. There was a lot of opportunity to learn, and that's all we really wanted. And so, like I said, he'll be 11 in February, and we're so grateful to have NEC Society around today. We see it benefiting so many families. So thank you, Jen. Thank you, NEC Society, for having me.
Cristal, that was very powerful. Thank you for sharing that. And I think, very sobering to clinicians. I think we would agree that the communication is nowhere near where it should be, just in the clinical care. And then I think once we get outside of that circle to more of the clinical research effort, I think even more sobering that families are even further away from the activity and the planning and the implementation. So I think we have a ton to learn from you, and I really appreciate you sharing that story. Seth looks like an amazing young man. So this is a real pleasure and a huge opportunity for me to be able to present data from the NEST trial. We call it the NEST trial because the real name is this whole slide full of language, but it was a randomized trial of laparotomy versus drainage in extremely low birth weight infants. So that's those less than 1,000 grams at birth with necrotizing enterocolitis or intestinal perforation. So again, thank you for allowing me to present the data. So I have no disclosures. So I moved slides around a little bit just to acknowledge, this is sort of beyond a team effort. If you think of the NFL with teams, this is sort of more like a league effort. There were 21 centers that participated over really a 10-year period of doing the trial. And there was really almost a 10-year period leading up to the trial where we did preparatory studies to help design the trial, acquired funding, designed the trial, et cetera. So it's really, a couple of decades of work. So these are the participating sites. And if you pictured each site having really three categories of sort of principal actors, so neonatology, pediatric surgeons, and follow-up personnel. There's hundreds of people that were involved in this study. So this is a real testament to the NICHD Neonatal Research Network to be able to get this done. This was really their first and only so far surgical trial aimed at trying to figure out better care for extremely low birth weight infants, and also just a real gratitude to parents of all the involved infants. Most of the clinicians are also parents, and we can just imagine having the sort of devastating diagnosis discussed with us, and then being approached about studying it. It's hard to imagine how difficult that would be. So why did we do the trial? So again, back in 2010 or so, we felt like there were important gaps in knowledge to be addressed with the study. There had been several prior trials, but neither of the previous trials looking at laparotomy and drainage had looked at outcomes beyond hospital discharge. So I think just like the polling question responses indicated, longer term outcomes were not on the radar as much as they should be for at least surgeons, especially taking care of babies with NEC or isolated intestinal perforation. So again, no trial had been done to address that. So that was really one of the main factors driving the NEST trial. And then the second one, I think is also really important, is there had been no previous trial looking at the impact of the exact diagnosis. So we talk about babies having NEC as sort of one group, but we all know it's a very heterogeneous population. And for sure, two different categories within that population are those with true necrotizing enterocolitis and those with an entirely different disease called intestinal perforation. It's sometimes called spontaneous intestinal perforation, poorly defined, but no one had ever formally addressed the impact of that distinction prior to surgery on the outcomes with the two standard surgical approaches. So those were our main intentions. The primary hypothesis, again, these are pretty sobering numbers, just when you think about 80% of one group and 65% of the other group either dying or having impairment. Those are really big, large numbers that are terrifying. And we didn't just pull these out of the air. Again, I mentioned we did a prospective observational study prior to the trial that helped us design the trial. And these were the numbers that we saw to be true in that prospective observational study. We hypothesized that there would be no significant interaction between pre-op diagnosis, again, that's NEC or IP, and the initial treatment. We thought that which of those two diseases you had was very impactful and influential, but we thought with a fairly small sample size, we wouldn't actually be able to show that statistically. So again, this was conducted within the Neonatal Research Network. And for those of you that don't know about that network, it's funded by the NICHD. It's a competitive U01 process across the US, and their really claim to fame and history has been doing difficult trials in tiny babies, and they've had a huge impact on the medical care for NICU babies, and this was the first surgical trial. So the trial was meant to be very inclusive. So if a baby was less than 1,000 grams birth weight, the surgeons thought they had NEC or IP and they were going to have surgery, we really wanted to have them in the trial so that we could, again, learn, from their outcomes. Again, this was a randomized trial, so extremely difficult for families, to hear about the diagnosis. This is an incredibly, severe illness. And then to hear on top of that, well, we don't really know which of these two different surgical treatments is better. We'd like to enroll your baby in the trial, which would then randomize the treatment. So that is incredibly difficult to ask. It's difficult to hear. It's difficult for neonatologists and surgeons who have very strong preferences of one treatment or the other. So that was one of the difficulties of the trial. But in doing that, it leads to the best scientific experiment, if you will, so that those data and those outcomes become very believable and might impact care. So exclusion criteria are those that are shown. Just for some of the trialists on the call, we stratified randomization according to the risk strata. So what we want at the end of randomization is we want the treatment groups to look as similar as possible. So in the observational study, we found these factors, I think there's 7 of them, that were very influential and associated with the risk of having death or impairment at roughly 2 years. So gestational age, birth weight, vasopressors at the time of enrollment, non-conventional ventilation or not, pH and FiO2, and surgeon's pre-op diagnosis of NEC or IP was also a very influential factor at the time of enrollment. Also, the study did allow, after initial drainage, subsequent laparotomy could be done. So again, the trial was more of a pragmatic or management trial in which, after randomization, then the care could be conducted by the center according to what they thought was best. So the primary outcome was a composite outcome of death or impairment at 18 to 22 months corrected age. And neurodevelopmental impairment was defined as having any of these items on the list. And again, this is sort of a standard outcome that the Neonatal Research Network has used over maybe the last decade or so. So it's moderate to severe cerebral palsy. It's low cognitive score on the Bailey, severe bilateral vision impairment, or hearing loss. So any of these things counted towards having a neurodevelopmental impairment. And then the outcome was the incidence of death or impairment between the two groups. We also looked at other outcomes: surgical complications, overall number of operations, duration of nutrition, parenteral nutrition and mechanical ventilation, and some other, there were many other outcomes examined actually. Our hypothesis, again, was that 80% of drain infants and 65% of laparotomy infants would have death or impairment. We did, again, this 4th bullet point, one of the, I think, what we felt like was most important, and I think now that we have data is one of the most important things, was to look at the impact of NEC, having the diagnosis of NEC or IP, how does that impact the overall outcomes with laparotomy or drainage? Because that had not really been looked at before. Certainly it's never been looked at in a randomized trial. So another feature was this Bayesian analysis idea. So again, it's not as common or as frequently talked about as sort of, what's called frequentist analysis. So again, this is getting into the statistical weeds just a little bit, but I think it's important. What we all want, I think, I would think as a parent, a provider, different perspectives, is we want to know what is the probability that laparotomy or drainage would result in a lower death rate or a death and impairment rate. We want to know that probability so that we can talk to the next group of parents and say, okay, we looked at hundreds of babies and we measured that outcome. I think it's important and true that only Bayesian analyses can give you that probability. The other types of analysis which give you this p-value are very frequently misunderstood. And there's this sort of dichotomy among investigators and readers of studies that if you have this p-value less than 0.05, then what you're reading is sort of gospel truth. And if the p-value is greater than that, then there absolutely is no difference in the outcome. So we can't get into the weeds any further than that, but I will tell you that there's a lot of really smart people that are now really emphasizing to downplay this dichotomous worldview based around the p-value. And Bayesian analyses actually make a lot more sense to some of us, and we'll talk about that in a little bit. So how did we do? So again, a lot of lead up, prior studies, funding, blah, blah, blah. So the trial finished in March of 2017 as far as enrollment. So this was a 7.25 year enrollment period where we screened close to 1,400 babies, all less than 1,000 grams, all with NEC or IP who were getting surgery. We randomized 310 of those babies. 148 had initial laparotomy, 162 had initial drainage. We did lose a very few babies along the way from data collection, and 2 withdrew from the study. But again, a testament to the Neonatal Research Network, we had a 97% follow-up at this near 2-year later time point, which is pretty amazing. And again, just total testament to the network. So looking at how similar or different the groups are, I will tell you that they were very similar. So they're all very immature, gestational age 24, 25 weeks. They're very small, 700 grams. And you can look at these sort of similarities for yourself. One difference sort of pops out, that 10% more of the drainage babies got postnatal steroids prior to their initial surgical treatment. Not sure exactly why that was, but that is potential, plays a role in our findings. Also looking at other characteristics, these are more sort of levels of illness between the 2 groups. Again, looking at laparotomy babies in this column versus drainage babies in this column. Age at enrollment's the same. We'll just pick one, vasopressors, more of the drainage babies, 8% more were on vasopressors. And then you can see these other findings. I think a really important couple of rows is this last one on the slide. Is we talk about NEC, and a lot of times when we say NEC, we are meaning the broader population that also includes intestinal perforation. I think it's time to move beyond that based on some of the data I'm going to show you. And we did look at that in this trial in a very detailed manner. And so surprisingly, at least to me, I would have guessed more 50-50 or maybe 60% NEC, 40% isolated perf, something like that. But I think it's true to keep in mind that the NEST trial did really sort of overrepresent infants who had presumed isolated intestinal perforation. So 70% of the babies in the lap group and roughly the same in the drainage group had isolated intestinal perforation as diagnosed by the surgeon before surgery rather than NEC. So that's an important caveat. We also, not shown on this slide, is I mentioned this risk formula, which takes really all of these things together and gives you sort of the risk level for the primary outcome that we're looking at, which is death or impairment. And the laparotomy group had a 63% risk for that primary outcome, and the drain group had a 71% risk of that outcome. So slightly higher risk in the drain group. So looking at outcomes now, again, I've mentioned our primary outcome many times in this talk already. And when you look overall, so what I mean by overall is all of the babies in the lap group and all of the babies in the drain group without considering the NEC versus IP distinction, then truly no difference. So 69% of the babies in the lap group had death or impairment, and 70% of the babies in the drain group had death or impairment. And this is strikingly similar to me from the Larry Moss's trial looking at lap versus drain, which was published in the New England Journal, I think in 2005-ish, which again showed that when you look at overall groups, without digging into who has what specific diagnosis, there's no difference. That trial only looked at mortality, but had a relative risk very similar to this 1.0. And I think sort of editorializing here a little bit, had we stopped here, so had we just stopped at this row and above, I think this would have been another New England Journal paper or JAMA or wherever we had submitted it, that, okay, we randomized all these babies, we looked at lap versus drain. The new wrinkle here is we're looking at neurodevelopmental impairment, whereas no trial before that has done that. And lo and behold, there's no difference. Clean message, easy to talk about, easy for editors to accept that. And I think that's what would have happened. And I think we would have been totally missing the point. So luckily we didn't stop there. We did look at what is the impact of NEC or IP. And it's listed at the bottom of here, but I've separated it out on the next few slides. So I think the truth is much messier once you include the impact of the pre-op diagnosis of NEC or IP. I think it is necessary that we hear this messy truth to make advances, but for sure, it's much more complicated once you start talking about the two different diagnoses. So I'm going to try to walk through this simplified manner as possible. So this slide I'm showing is all about NEC. So this is all about 94 babies that had a pre-op diagnosis of NEC. And if you look at the primary outcome, death or impairment, that happened in 69% of babies with laparotomy and 85% of babies in drainage. So pretty reasonable difference if you were just looking at this as a parent or a surgeon, 16% higher, absolute percentage higher of that very bad outcome with drainage. And then when you do some of the standard statistical analysis, that gets you an adjusted relative risk of 0.81. And this is an example of sort of frequentist versus Bayesian. So this is more frequentist analysis. So a relative risk of 0.8 favors laparotomy as far as reducing this poor outcome of death or impairment. But you don't know that this is for sure the gospel truth. So we do this 95% confidence interval, which shows that, well, it could be really favorable at 0.6, but it's possible that it's actually harmful because this now goes across 1.0. So this would be a p-value greater than 0.05. And again, some thinkers, a lot of thinkers actually, who look at studies and do studies, if your view is anything over p 0.05 means no difference, you would immediately say this is just coned down to no difference. That doesn't make sense to me. Luckily, it doesn't make sense to a lot of people much smarter than me. So let's look at the Bayesian. So on the right panel of this screen, there's two different graphs. So the top one is relative risk or risk ratio, and the bottom is risk difference. They show the same thing, really. So let's just kind of pick this one at top. So what all the Bayesian does is it says, well, let's take all of the information about laparotomy and drainage for NEC that exists prior to the study. Let's take all of that together. And what is the prior probability that laparotomy is better? Well, I mentioned that no one's ever done a randomized trial looking at impairment beyond hospital discharge. So there's really no great data there. So what we said was there are no real data indicating that one or the others of these would be better. So we have what we call as a neutral prior. So that just means that prior to starting the study, we think there's an equal probability that laparotomy and also drainage could be beneficial for babies with NEC. We then do the study and get these outcomes that we got. And then we apply that to get a posterior probability. So we started neutral, we acquired results, and then at the end of the day, at the end of the study, there's a 97% probability that laparotomy is better. And by better, I mean a lower death or impairment rate than drainage. Now, it's not perfect. It's not certain, but it's 97% probable and only 3% probability that it's harmful. So this is the IP slide. So same data, but now the different diagnostic subgroup of those who were deemed by the surgeon pre-op to have isolated intestinal perforation. We had more of these babies, 201. So interestingly, the percent of babies with death or impairment after laparotomy is exactly the same as for the NEC group, 69%. But this time, drainage had a slightly lower risk for death or NDI. It's not huge. It's not as big a difference as with neck. And if you look over here at the Bayesian probabilities, same starting point. But here, the probability that laparotomy is beneficial for this group of babies is only 19%, or stated another way, 80% probability that it's actually harmful. So we did look at other outcomes that also would influence clinical decision-making. Again, one of the issues with drainage, as we heard in Seth's course, was, how many of the babies that get drainage are going to need a laparotomy anyway? If every baby that got an initial drain required a laparotomy, then you might always start with a laparotomy. So in both subgroups, NEC and IP, it's roughly half of the babies in this study who got initial drain got a subsequent laparotomy. It's higher in the NEC babies versus the IP babies, but not dramatically. I also thought it was interesting that even when you start out with an initial laparotomy, I think this is good for parents and providers, about a quarter of the babies are going to get another laparotomy, even if you start with a laparotomy. Complications, also a very important outcome. So let's say that we took the IP data I just showed you and the Bayesian probability that laparotomy is not helpful. Well, this helps us look at complications rate of doing the laparotomy. So in both groups, there was a 20% incidence of intraoperative complications with laparotomy and a lower rate with drainage. And some of these complications are pretty big and scary. So the most common one is liver hemorrhage. And again, all the surgeons on the call are fearful of this. And when you have this, there's a high mortality rate. So I think the complication rate is another piece to the puzzle. So one thing that's challenging about the trial is I have mentioned up to now the pre-op diagnosis of NEC or IP had a big influence on the treatment effect. And in my opinion, it's the biggest contribution of the NEST trial because it's the first time that a randomized trial has ever sort of delved into that. And I think it gets us closer to this sort of personalized medicine concept where each baby is going to get the right treatment at the right time. At least we have gone from an overall population of NEC, which includes a bunch of things, to now NEC and IP. But there are challenges with that. So one of them is when we look at the agreement between a pre-op diagnosis and an operative diagnosis in babies who get LAP. So again, our numbers get smaller and smaller. So 138 babies had a LAP and had data. So, that's less than half of our overall number. So it's sobering that these two different diagnoses at two different times only agreed 64% of the time, which is obviously not great. Now, it was better when the surgeon said and recorded that it was pre-op diagnosis of NEC, that was in agreement with the operative finding 78% of the time. However, with IP, it was much lower. This is also a very important finding, is that 7% of the infants who had one of these two diagnoses were actually found to have something else at laparotomy. So I think there's lots of work to do on this, and maybe we can talk about this in the discussion phase. And I think this is my last slide. So in extremely low birth weight infants with surgical NEC and IP, again, one of the sobering findings is that mortality and impairment is just very common, 70% overall, which again goes directly along with the mission of the NEC Society to prevent NEC. that's obviously what is needed. My thought has always been, until we get to that point, I think surgeons and neonatologists have a responsibility to study the available treatments, even if they're not amazing. We want to know how to use those treatments in the most optimal manner. When you look at babies overall, these treatment groups overall, without trying to distinguish the diagnoses, then you literally see no difference, and we've shown that again. However, again, big contribution of the NEST is if a specific diagnosis modifies the treatment effect. And my view of this is that when there's pre-op diagnosis of neck, I feel like the data show laparotomy is beneficial. It's not perfect. There's some uncertainty. There's always going to be some uncertainty. And with a pre-op diagnosis of IP, there's even more uncertainty. I've shown you the data, from the NEST. And I really think probably the pre-op diagnosis of IP group really needs the most further study as far as surgical treatment. Thank you very much.
We're going to open it up for our panel discussion. So if everyone wants to turn on your cameras, and I will do some quick introductions. So I'll start by introducing myself. I'm Jennifer Canvasser. I'm the founder and the director of the Neck Society. I lost my son Micah to complications of the disease just before his first birthday. So he was diagnosed with neck when he was 6 weeks old, came home, but had a lot of complications from neck and then died just before his first birthday. Cristal, do you want to introduce yourself for anyone who joined late, and then we can just go around?
Sure. I'm Cristal Grogan. My son Seth was born at 29 weeks and is a survivor of surgical neck, and he will be 11 in February.
Thank you. Marty, I know you just presented, but do you want to give a quick introduction of yourself?
Yeah, so I'm Marty Blakely. I'm a pediatric surgeon at Vanderbilt now. When we started devising this study, I was in Houston. It was back in around 2000, and had the opportunity to work with John Tyson, who is a neonatologist and noted clinical trialist, who was able to take this question and bring it to the Neonatal Research Network. And again, I just want to really thank the network and shine a light on them, because this study took 10 years. And I think Rose Higgins and Drew Bremer and other leaders allowed this study to go on and be funded that long, whereas plenty of other sort of avenues would have cut this off early. So just a real thanks to the network and also the NEC Society for allowing us to present the data here.
Thank you. David, you want to introduce yourself?
Hi, everyone. I'm David Hackam. I'm a pediatric surgeon also. I'm the surgeon in chief at the Johns Hopkins Children's Center. It's a pleasure to be here, and congrats to Marty on this incredible study, and condolences to the families who have suffered through this terrible disease. And we're here to help you.
Thank you. Toby?
Hi, everybody. I'm Toby Yanowitz. I'm a neonatologist at the University of Pittsburgh and Children's Hospital of Pittsburgh. And I have been working with the Neck Society, helping to come up with an agenda for research in the future. So I'm happy to be part of this panel and hope I can contribute some knowledge to everybody.
Thanks, Ravi.
Everyone, I'm Ravi Patel. I'm a neonatologist at Emory University and Children's Healthcare Atlanta, and I'm a scientific advisor to the Neck Society.
Awesome. So we're going to go ahead and get started with our panel discussion. It looks like some of you are already voting, which is great. Ravi's going to be moderating, so Ravi, feel free to jump in and take it from here.
I thought it'd be great. These are just some questions that we thought we'd love to hear from the attendees, and also to get the thoughts of the panelists. As Marty, you mentioned, some of the prior trials before NEST looked, focused on survival, whereas this was really focused on both survival and longer term outcomes. I wonder if you could tell us a little bit about kind of what went into the calculation of deciding what the right outcome was for this trial.
Yeah, thanks, Ravi. The observational study, which we published, I think was also around 2005, and I referenced in one of the slides. It was interesting because we did that study So again, that was just a prospective observational study where there was no intervention. The neonatologists and the surgeons treated babies as they thought was best, and then we simply recorded the outcomes. And at that time, there was this big debate about whether laparotomy or drainage had a difference in mortality, and very emotional arguments, which is appropriate when the mortality is so high. So that observational study, we didn't do that to try to figure out which of these things is better. We did that study to try to figure out what a trial should look like. And in that trial, by adjusting for differences between group, we showed that there was no difference in mortality, but it looked like there at least was some sort of signal that laparotomy may be beneficial to reduce neurodevelopmental impairment later. And there are examples which you and the other neonatologists on here know much better than I do. There are these examples in neonatology where a very early treatment could have really much later impact on neurodevelopmental outcomes. And it's only when you know the results of those neurodevelopmental outcomes do you then know kind of how to recommend that much earlier treatment. So I think we felt like this could be another example. And you might think, well, why would laparotomy versus drainage have an effect 2 years later? And I think from parents and all the providers, we know how different those two lanes are. The drain might seem more favorable, less intimidating because it's a less invasive thing, but you don't really know kind of what's under the abdominal skin. You don't kind of know what's going on. Like Cristal was talking about, there was this huge wait. So it's possible that you get less sort of control of that, really severe thing going on inside the peritoneal cavity. And that laparotomy, maybe you get better control of that. So these are all just sort of potential mechanisms that we thought about. And we really felt like getting the longer term outcome directly on the radar was incredibly important.
Thanks, Marty. And I wonder if other panelists have thoughts on, as you're thinking about treatments, is this the most important outcome that we should be focused on as opposed to something much more short term?
Ravi, I would just like to mention, I think, there is this national trend toward all neonatal studies, including some aspect of neurodevelopment, because so much of what we do can affect babies' fragile brain development. But for necrotizing enterocolitis specifically, there's one outcome that I really didn't see mentioned at all in the NEST trial, and I wonder if Marty has data on that, which is short bowel syndrome. So I also work with the Children's Hospital Neonatal Consortium, and we published a paper. It is retrospective. It's just chart review study, but we had 500 babies who had NEC, and we found that babies who had a laparotomy compared to a drain had equal mortality when we corrected for those illness severity things. But if they had a laparotomy first, they were more likely to have short bowel syndrome. And especially when we're talking to families with NEC survivors, having short bowel and all the years of intestinal rehab, it's not an insignificant finding. And I wonder if Marty has any data on that just maybe didn't make it to the publication.
Yeah, so luckily I have my publication in hand since I don't remember all 1,250 outcomes, but we do have in the paper, table 4, there's a measure of final bowel length, which is not exactly what you were asking, but it's sort of a measure of that. And if you look at in the NEC babies, really no difference. It was 63 centimeters versus 64 with the drainage, so really no difference. And then in the IP group, pretty similar. So we do have, in addition to that little sort of high level finding, we have multiple secondary analyses of the NEST data set that are being conducted now. And one of them is purely on growth and nutrition, looking at the extent of disease and outcomes after each of the two different treatments.
Can I, that's really helpful, Marty. To the question about, is this the right endpoint? It's certainly a very important endpoint and has been underappreciated. And I think this paper sheds light on two things. First, neurodevelopment impairment is very high when you have NEC. And we've known this for a long time. And we have data from mice, but also humans, that suggests that when you have dead or dying intestine, which you must have with NEC, that's where the word comes from, the brain is taking a hit. While the gut is dying, it's releasing molecules that cross into the brain, and they essentially destroy the myelin in the brain. And so you get this white matter injury, which manifests as learning impairment, autism, and depending on where the injury is, potentially neuromuscular impairment. And we've known for years that NEC is associated with worse neurodevelopment impairment. This study, by showing that removal of bowel, which presumably would occur with laparotomy, versus drainage, which presumably allows that bowel to remain for longer, and that's, of course, compensating to some degree for those patients that require recurrent laparotomy, but at least the bowel staying there longer. The fact that neurodevelopment impairment is worse with drainage supports that notion. And so the first point I would make from these data is that we think that earlier surgery by removal of dead bowel will be neuroprotective as we're waiting for neuroprotective therapies, drugs we can give to protect the brain, and we're working on that. That's the first point. Second point, though, is Toby makes this great point about short gut. So assuming that that retrospective data set is pure and distinguishes NEC from SIP and mortality from NEC versus mortality from other causes, all the pitfalls of retrospective data that Toby was alluding to when she commented that they're retrospective, we cannot ignore the fact that short bowel syndrome is a devastating long-term complication in patients with NEC. And whilst we want to preserve neurocognitive function so that our kids grow up and can meet their full potential, it should not come at the risk of short bowel syndrome, which in and of itself is a devastating outcome with a mortality rate. And so I would offer that to the first point, we need to develop neuroprotective therapies and operate earlier. And to the second point, while we're waiting for strategies to grow bowel and to enhance existing bowel, and there are labs working on that, we also need to look at how we do the operation. And that really, and the surgeons would agree, is undergoing some, I would say, reimagining. We've always known that we have to take out just enough and not too much. But I think groups are now using a wait and see approach, doing staged operations, not committing to taking out at a first operation, putting in a silo, allowing perfusion to distinguish what's alive, what's dying, what's dead. The modification of the clip and drop technique that others have written about, Agostino Piero and others, probably Nigel and others. And so I think the next phase will be to target what Toby's talking about, and let's refine the surgery in ways that preserve bowel optimally, perhaps using off-the-shelf products to augment the bowel while we are protecting the brain. And this paper, I think, supports both those approaches.
David, before we move on to the next question, I wanted to see if Cristal or Jen had any comments regarding this question.
Yeah, I think as a parent who's now dealing with those, the neurodevelopmental issues, I find it extremely important in what I'm facing. Especially, even with him at 10, I know a lot of long-term studies stop at 2. But, I think it gives us an idea. I think when we talk about protecting the brain right away and being able to kind of preserve the health of the brain while we're kind of dealing with, surgical decisions and trying to decide, what the best route is for treatment, I think is exciting. But as a parent who is dealing with those neurological issues, and like I said, now kind of creeping into mental health issues, I think this is one topic that really hits home, and that I find is one of the most important ones on my list that I look at, that I would love more information on, and would love to explore more, just because it factors in so many different ways, whether it's educationally or developmentally, or language, or and so there's always been that curiosity of what we could have done differently to protect that neurological impact that we're now facing and will always be facing.
Yeah, thank you, Cristal. And I think I would just add that, my son Micah did initially survive and spent many months in the hospital in the PICU before coming home. But he had short bowel syndrome, and he had end-stage renal disease, he had liver disease, and he had lung disease, and it was all stemming from his original infection with NEC. So I think, again, just those complications and the other things that come along with NEC are really critical, because quality of life, obviously, are really important. So as much as I would like to focus on survival, I think I even myself, having lost a child to NEC, recognize really the importance of quality of life. Should we move to the next question, Ravi?
Yep, that sounds great. Thanks, Cristal and Jen.
Yeah.
I'd love to hear, and while our audience is maybe putting in their thoughts, Marty, you mentioned this took 10 years as a trial. This was a Herculean effort for a lot of clinicians and centers involved. I wonder if you could talk about some of the challenges of NEST and some of the things that make trials like this difficult.
Yeah, I think it's really the top one there. Again, we wanted this to be as inclusive as possible. Obviously, when you do a clinical trial, a randomized trial, one of the problems in neonatal surgery is just numbers of babies. While NEC is a huge problem, it's a global problem, like we talked about. It's not like adult cardiac disease where there's hundreds of thousands of people, or like an oncology trial, for example. So when don't get me wrong, we have too much of it, right? We have too much NEC and we want it to go away. But when you want to try to study it, you need more numbers. And so we wanted it to be as inclusive as possible. And one of the problems in the trial is there were babies that would be identified as eligible. So they had the right birth weight and they had the right age, but they were, just terribly unstable. So, maybe even CPR type measures going on at that time. So there were a lot of babies, more than you would think, that were in that category that were determined to be eligible, but there's just no feasible way to, get that baby in a study like this, which requires talking to the family for a long time appropriately, maybe, talking to the family more than once, getting consent, all of those things. And so that, really that problem of just how, severe the condition is, and some, usually it's 2:30, 3 in the morning somehow, that directly led to the length of time the study took. And also, the sort of normal critic should and does say, well, it's great that you did all these things, but about 70% of the eligible babies with this condition didn't really get in the trial. Which is true. We randomized about 1/3 of the eligible babies. So I think that, to me, is the biggest challenge. The other things on this slide were challenges to some of the study personnel, but really sort of paled in comparison to acuity of illness. And also, I will go ahead and mention sort of provider bias. We all bring to this equation strong feelings and anecdotal experiences about using one or the others of these therapies. And we did have multiple times where a surgeon or neonatologist said, okay, I'm incredibly supportive of the trial in general, but for this baby in front of me, I think we should do X, or I think we should do Y, therefore, I won't randomize them. So that comes along with any sort of randomized trial, but just sort of the emergency nature of it was incredibly difficult.
Thanks, Marty. I wonder if you had thoughts, in terms of approaching families for a trial like this, where it might be a smaller, shorter surgery versus a much more involved surgery, and how did you balance that, and maybe to surgeons in terms of the way they would explain this going forward, when you have these two choices that are very different surgical options?
Yeah, I'm going to take the easy way out of that question and just confess that, it typically wasn't the surgeon seeking consent. Some places actually mandate that it's not the treating surgeon or physician. So I think that really did fall to the professional clinical research coordinators in the Neonatal Research Network. But just in general, I feel like, an honest discussion of this problem is that, we know so little about it. And as long as I, as a surgeon, could feel comfortable that one of the other therapies was, roughly equally likely to be best, which that's what we said, and that's what I firmly believed at the time. Then if you can meet those assumptions, then treating a baby in a trial setting really offers a lot of benefit. I mean, number one is you may get the answer to the question, and then you can help future families from now on. But also, just in doing other trials, is when you take care of a baby outside of a clinical trial, you for sure are doing your best, and you are doing your best to communicate and do all the things. But once you get randomized into an NIH-funded trial, it's a different level of surveillance. So, there's all of a sudden new people looking at the outcomes of your baby. So I think, and there's plenty of studies showing that being on a trial versus not being on a trial is actually safer. So, that's sort of a no answer, I guess, to your question. But it is incredibly difficult. And I think it's one thing we definitely could have done a whole lot better. And I talked to Jen a little bit about this. As soon as I finished the trial, I did have this sort of sobering thought, kind of, that we had a 10-year project and we didn't really include families. And what an opportunity missed for that. There was a little bit of involvement here and there around some of the consent issues, but again, I think whatever younger investigator is going to do another thing kind of like this, I think just load the boat with as many families right up front as possible, to be a critical part of the team.
Thank you.
Marty, I just want to take a minute to step back and commend you on having completed this trial. Although we listed the enrolling in the emergency situation as a challenge, I think that's really one of the big strengths of this study. I've done a bunch of clinical trials where we had to enroll baby by 4 or 6 hours of life, but to do it, when you have a baby with a perforation in front of you who needs emergency surgery now, and to talk to the families and bring them to an understanding of the importance of the research and the benefits to their baby for being in the research, when they're just beside themselves. It's very challenging and very emotional and very different than enrolling for some of these. You talked about, adult cardiac disease where there's hundreds of people, but the emotions are not quite as high with an adult, and the urgency is usually not there. So I commend you and the NIH and the study team and everybody who took part, because it's not easy. And I think, yes, it took 10 years, but you got to your final N. We were worried along the way that you were going to have to stop prematurely and not even get any results from it. So it's really nice to see that you were able to complete the study. The other thing I want to highlight is, with the neurodevelopmental impairment being one of the main outcomes, the other things that is excruciatingly hard in these, especially multi-center studies involving preterm babies, are notoriously hard to track and follow up. They come from a variety of social situations that just run the gamut of, reasons why they're born prematurely and the resources that the families have. And to have 97% follow-up is, up on par with the best neonatal studies that have ever been done. So I commend the study team for that as well.
Thanks, Toby. I think we can go to the next question we have here, which is about Bayesian analysis, which I know, Marty, you touched on. And this is from the poll when we started this webinar, was something that a lot of people said they weren't familiar with. And I think you highlighted and made the nice point about thinking kind of dichotomously as a yes, no, versus more in terms of probability and uncertainty. And I wonder how you would think about kind of interpreting, for example, for babies who had intestinal perforation, there's an 81% chance that laparotomy is harmful. How did those probabilities then translate into kind of an action that needs to be taken of a choice of one treatment versus the other?
Yeah, I think I should have invited a statistician to this panel, but I mean, part of it to me is what level of evidence should a provider require in order to use those data in their decision making? That is what I've thought about a lot lately. And I'll just tell you that when we finished the trial, we submitted this to JAMA first, because I just felt like over time, New England Journal was used to very simple stories, treatment A versus B, no difference, boom, great study, helpful. Whereas JAMA could sort of get in the weeds and work with difficult stories. And I'll tell you that JAMA and New England Journal, which was our next journal, both had this total dichotomous thinking. Your outcomes are interesting, but p-value 0.06 at best. You must declare at the end of this, there is no treatment. And I honestly believe that had we agreed with the JAMA review process and said that's where it would have been published, but we felt like that was actually harmful, because when we looked at the data, even though there is uncertainty there, we felt like if you said there's no difference based on those data, so let's take it a step at a time. If you said there's no difference, number one, and number two, if it is true that laparotomy is better for neck, then I think you could actually do harm, because if there's no difference, some people will take that as, well, I'm just going to do the most simple thing at 2 a.m, which is a drain. So anyway, I think I think there is uncertainty still. But I think if we do a trial that takes 10 years and randomizes 300 babies with the outcomes that I showed you, and your take on it is, well, that's not enough for me, I need the P less than 0.05, you might as well say that you aren't going to use any data in your decision making from now on, because the only way to get lower than that is maybe a 20-year trial or 15-year trial with more numbers. And so I think I am really interested right now in pushing this question of what level of data do you need, should you need, to consider in your clinical practice. And so I think the Bayesian helps on that. Again, I'm not ready to take that 80% probability and, run through the streets and say we've answered the question. Now the 97% probability with NEC, I probably am. But I think these data, they aren't perfect. They're messy. The whole diagnostic distinction's messy. But I hope people will just think about them as they face these babies in the NICU. And I'll tell you that my practice has changed some, at least, where when I get a consult about this now, I am 100% about trying to distinguish the two different diagnoses first, which I didn't before. I sort of did, but maybe not as strongly as I do now.
And can I just add something to that? We struggle with this. So I agree with everything Marty said. And again, I echo Toby's comments. This was a Herculean effort that wouldn't have happened without Marty, even though everyone else participated. So you've done the field a great service. So thank you. So just two things. The first, when we decide to operate on a child with NEC in 2021, it's a different set of data points that we have access to than we did 10 years ago. We had the Larry Moss trial, which also, I believe, similarly, not only did the outcomes, the short-term outcomes mirror, but the percent of recruited versus not recruited children that they follow was about the same. I think about 2/3 were followed but not entered into the trial. And so that tells you about how complex this is, I suppose. But with these studies, we've also learned more about the disease. And from many labs around the world, we're learning what leads to the disease. We're learning how the microbiome activates an immature immune system leading to death. And these have, I think, allowed us to recognize that NEC is different from SIP. And we know a lot about NEC. We know very little about SIP other than it's not NEC. And this data supports that. It's the best data I've seen to support that. And many data sets have included both NEC and SIP. The New England Journal paper certainly did. If you look at patients that had no pneumatosis and just free air and were randomized, they were very different than the overall group. That was a subset analysis that really looked at SIP without looking at SIP. And so we've learned from this that SIP is different. The other thing we've learned from studies done in the field is that there is a point at which NEC stops becoming medical and starts becoming surgical. And that's probably much sooner than people appreciated in the past. So much so that NEC might be seen as a surgical disease masquerading as a medical disease, as opposed to the other way around. That's obviously perhaps an extreme viewpoint, but it's called necrotizing enterocolitis for a reason, not maybe soon NEC or on its way to becoming NEC. If we're calling it NEC, at least stage 2 NEC. In every other instance, necrosis is a surgical condition that cannot fizzle its way out through a drain, unlike SIP, which can, because it's a small hole that'll close. And so our decision-making will be influenced by Bayesian analysis, p-values, et cetera, but also by a greater understanding of the disease. And many people that are participating deserve credit for those insights as well.
Thanks, David. And I wonder, Marty, if you have thoughts on kind of the opportunities to address some of the uncertainties within the trial itself, as you kind of highlighted, potentially related to the pre-op, the diagnosis, in terms of getting that diagnosis right, which might be important to make the choice. And I wonder if you could touch on maybe how we can help clinicians with kind of that preoperative diagnosis.
Yeah, I think I would say that the NEST study doesn't have an amazing amount to say about that. It was a secondary or tertiary sort of effort to look at the correlation of the pre-op diagnosis and the intraoperative diagnosis. There's never been really any sort of prospective formal investigation of that question. And whenever we say that the pre-op diagnosis and the intraoperative diagnosis don't agree, we immediately say, oh, well, we don't even say it. We just assume that the preoperative diagnosis was incorrect. But there's never been any sort of study looking at the intraoperative diagnosis of these two conditions. And I believe there's a lot of variability in that. We are in these different silos. So neonatologists, I don't think very often see what this looks like at operation. I mean, maybe on occasion. But I think what one surgeon calls a very short segment of neck, another might call it SIP. Now we are looking at this. So when I talked about NEST not having an amazing amount to say about this, how we measured the quote surgeon's pre-op diagnosis, I think had some methodologic issues. I don't think it was always the surgeon. I think it could be a fellow, could be neonatologist, and maybe they would have more accuracy or less or different, but it just wasn't the focus of the study. We are going to look, another secondary analysis is to say, okay, let's set aside that one data variable that's recorded as surgeon's pre-op diagnosis. And what I also should mention is that in addition to the 308 randomized babies, there are 226 other babies that were treated in the same manner and had the exact same data collection, including all the way out to the 2-year mark, similar follow-up rate. So if you mix all of those together, potentially, I'm interested in looking at all of the factors that we recorded getting at that intraoperative diagnosis, independent of what the surgeon maybe recorded. So I can see some sort of modeling based on this extensive data set, which is all collected prospectively. But where I would really like to go now is designing a prospective observational of some sort. Hopefully I can get David to help me with this. Looking at new radiologic, ultrasound use, whatever new biomarkers there are. I would really like to jump in a strong manner of trying to improve and investigating the distinction between the two diseases.
Yeah, I think that's critical work. It's easy when it's easy. Day 1 to 3, known risk factors, tiny kid, never been fed. But it's hard when it's not that. And also we're seeing more premature babies being born at younger age groups and being kept alive, which is perhaps another conversation. But these, a 22-weeker or 23-weeker is barely recognizable as a 34-weeker. And so we cannot expect their guts to look the same. And therefore, when they get intestinal problems, and they get their own intestinal problems, they get dysmotility, and I suppose they will also get neck in a different way, because we know that neck, as was mentioned, is not just one disease, it's a heterogeneous group of different diseases with overlap. And so there is a real need, not just to understand treatment and other therapies that protect the brain, protect the gut, but that are accurate diagnostics. The era of abdominal X-ray, physical exam, and risk factors has to end, and we have to use biomarkers, imaging techniques, and molecular assays. So Marty, let's do it.
Thanks, David. And you touched on really two of the questions that came from the audience regarding biomarkers as well as ultrasound in terms of improving the diagnosis. I wanted to touch, if you go back to that last slide, Jen, kind of would you agree with this? It seems like there's a majority here that would say peritoneal drain placement should be the initial choice of treatment. I wonder what your thoughts are, maybe starting with our surgeons, Marty and David. What would you say given the trial results? Yeah,
certainly. I will just confess that I had, coming into the trial, just had a bias to do laparotomy for really all the babies, and just sort of considered that if I did a laparotomy and I found a SIP, well, then that might be the easiest laparotomy, that I'd done in a while. And I think seeing the data sort of corrected me a little bit away from that. Just seeing, the 20% intraoperative complication rate from a laparotomy with a SIP is pretty sobering, and some of those are very scary complications. So, I am more aligned with these responses than I was before. But I see the question as sort of unsettled in looking at all the data analyses together.
Yeah, that's right. And I think adding to that is, so my go-in for any baby who's got a potential, who has potentially perforated neck, is to operate. And so there's a large subset of patients with SIP that you're just not that sure about, as the study shows. And so putting in a drain will perhaps, as the study also showed, delay the laparotomy they needed 2 days ago. And this whole time the brain is getting pickled. That's a technical term. But this question needs a little more nuance than diagnosis alone. It needs nuance regarding size, and I suppose gestational age, but certainly size. So a 600 grammer with a 2 day of life, free air, is a drain, versus a 1100 grammer, 9 days of life, who also could have SIP, is an XLAP. Where this patient is, in many centers, premature infants are managed very well outside of AMCs, where there are pediatric surgeons on call, AMCs, academic medical centers, and the surgeon will get a call for free air. And the resources may not be there to do a laparotomy, but it may not be the right thing to transfer that child. And so the resource considerations outside of a large children's hospital where this panel works are also very important. So it depends. And so I think the study needs refinement of diagnosis and substratification at various different levels of age and size. And then we'll get to this. And close monitoring. No one walks away after doing a laparotomy. No one walks away after putting in a drain, but it's not the end of the story when you just put in a drain.
Thanks, David. And thinking of these as two kind of comparable interventions or comparative effectiveness interventions, I wonder about, is there a role when there's uncertainty about shared decision making, and maybe from our families, is this something where if there's these two options and there might be some uncertainty about what the best option is, would you prefer to have a choice in that, or would you prefer just to say, surgeons or neonatologists, tell us what you think the right option is, and not have kind of this choice posed? I'm curious to see if there's thoughts about whether there's a role here for shared decision making, or if this is really not one of those treatments where that's feasible.
I think, Cristal, do you want to jump in?
Yeah, I was going to say, do you want to go? No, I think we both probably have something to say. As a parent, I always want to be part of that, discussion and part of that decision making. I think it's hard, like you said, there's so many factors to take into consideration, but especially, of course, looking back and knowing what we're facing now, I would love to have been educated about, what that gut-brain correlation is, and the longer we have this, because he did perforate, so as the longer we have this, the gut damage and how it's affecting that brain. Like I would have loved to know beforehand to help, and be in that discussion if I could in any way help make that decision. So I think it's, I think it would be extremely beneficial to have the parent as part of that discussion, as a decision maker, and really getting to feel like you're part of that care team and part of that decision. Sure.
Yeah, I totally agree. And I think it's just important for families to be invested in the decisions that are being made for their child, because a lot of them are life-altering decisions that will have potential effects for years to come. And so I think as much as we can provide families with the information that they need to be part of that, to help be part of that decision-making process, and so that they feel comfortable and confident in the decisions that are being made. It's really important.
And can I ask Jennifer Cristal question? And I'm keeping an eye on the time. The perfect world is this triad being on the same page: neonatologist, pediatric surgeon, and parental unit, completely aligned. That's the perfect world and the ideal. And the neonatologists, pediatric surgeons, we have an obligation to families to know on the balance of probabilities what the right course of action is. We should come to a shared decision. It's critical that the surgeon and the neonatologist are on the same page. It's also critical that the families are involved in the process, and we arrive after the neonatologist has developed a relationship. But we worry, at least I worry, about putting a family member in a position of having to make a medical decision. It's very different than being informed and being aware of the risks and benefits and being a voice in the decision. We have to be careful not to put the families who are dealing with the worst stress in their life of also having to decide. That should never, that's too much.
No, I totally agree. I don't think it should be for families to ultimately make the decision, but I think making sure that they have the information they need to understand why the decision is being made by the care team and recommendations along a certain path are being made, and so they're invested. But I totally agree, David, that parents should not be put in a position to have to choose.
Yeah, thank you. And we try and make everyone feel aware of what's involved in these life-altering decisions.
Okay, should I go to the next slide?
Yep. So this is an opportunity, as we're going to allow the audience to maybe put in some, as you've heard this webinar and the great discussions that we've had in the presentations, what are some unanswered questions you have after this trial? And as you're having a chance to enter these, I'd like to touch on some of the things in the Q&A briefly. The first is really about kind of the diagnosis of SIP versus NEC and how that was determined at centers. Was this a standard unified diagnosis? Was it up to the clinicians to choose the diagnosis? I wonder if you could touch on that, Marty.
Yeah, mainly the latter. So when we were designing the study, we did talk with the personnel involved in trial planning sessions that we were going to record the distinction, and here are data showing sort of what characteristics go with either diagnosis. But like David was saying, a lot has changed over 10 years, right? So one of the main ones is participants in the study. So we're a very mobile group. So the group that we ended up with doing the trial was not the same one that heard the sort of consensus thing at the beginning. But one of the takeaways for me was, imagine the noise, sort of statistical noise in the measurement of pre-op diagnosis of NEC or SIP in this study. So there's 21 centers across the US. Let's say there are 10 surgeons at each site, and let's say that half the surgeons participate. So well over 100 surgeons kind of, doing their thing out there and participating in the trial, and, bringing different levels of training, different levels of experience, different beliefs, and, the different diagnoses. And even with all of that noise, there was a very significant signal that what we call these things before surgery has a very important impact on the outcomes of the two surgical treatments. So that to me is encouraging, because again, I think there was plenty of opportunity for the signal to get lost in all the noise, but it sort of shone through in the end. Now, I think once you try to confirm what that diagnosis is, then that's the rest of my career's work, I think, is to try to help shine some light on that. So anyway, yeah, I think it was a lot of variability in that.
Marty, and I'm going to hand it over to Jen now. I really do appreciate all of the panelists for really thoughtful discussions, and it's been a great opportunity to kind of get in the weeds of this important trial.
Great. Everyone's welcome to leave their cameras on. This will be pretty quick. I just wanted to give everyone a chance to share any resources or tools that you would like to see available to families affected by NEC. And as you're thinking about that, I'm going to advance to the next slide due to our limited time. I wanted to share some resources that we have developed. We have a site, a page on our site where we have resources for different kind of groups. And one is for long-term survivors and their families. So that is available on our website. We also last year did a study with a survey study looking at the life impacts of NEC on survivors and families. And we are writing this up and we'll submit it for publication in the coming weeks and months. You can stay tuned for that. And then I just wanted to see if we had additional questions from our Q&A with our participants, Ravi, that we wanted to address.
Yeah, Marty, are you okay with staying on for a few minutes longer?
Yes.
Let me. There are. I wanted to touch on this question that comes in about kind of timing of intervention, and whether, I think, David, you mentioned about kind of the variability in surgical approaches and differences in operations, and I wonder if you could speak about how the timing of when a particular intervention was and how that might have influenced the outcomes.
Yeah, I would say, to be honest, that was beyond the scope of what we did. I think it's incredibly important. I think indications for surgery, we know also needs research, but I don't think we addressed that in the trial.
There's a question here about other factors that might have played a role, and this might be outside the scope, but things such as fortifier supplements. And I wonder if you have a comment on that.
I also don't think that was, we have hundreds and hundreds of data points, but I don't believe that was part of the data collection.
Now, I wanted to open up to the panelists as we finish up. If there's questions that you all had that we didn't have a chance to ask, or that you feel comments, I'd like to give the last few minutes to our panel to see if there's something that you wanted to bring up.
I would just again congratulate Marty for the work. And in terms of research priorities, we in the field are open to hearing from the community that's affected by this disease as to what we should be focusing on. And so this is such an important society as a conduit between all stakeholders. I do think diagnosis and diagnostic modalities and therapies and therapeutic modalities, including prevention and treatment, need to go hand in hand. And as we establish research priorities and as teams look to the future, I think the future is bright in the study of NEC because of these priorities and this society. I have to run.
Thank you. All right, should I advance to the next slide? Any other comments, questions?
So Jen and Ravi and others, I'm just curious, again, I would say, if you said, what is the main contribution of the trial? My own opinion would be shining a light on the differences in how things look between the two different diagnoses. So I'm curious, in the NEC society, has that been a focus of looking at, babies with true NEC versus those with SIP? And if it hasn't been a focus, is it on sort of your future study radar?
Absolutely, Marty. I'll speak, and then maybe Jen can add on. I do think that there's been a lot of focus on SIP, and then there's been this other disease that in many studies sometimes gets folded into NEC, even though, as you mentioned, it's a distinct disease. So there is definitely interest in trying to find ways to differentiate these diseases, and some kind of initial efforts by the International Neonatal Consortium. But I think a lot of work to do in that area.
Yeah, I agree. And I think in terms of, the Next Society's role, we try to be as inclusive as possible for families who have been affected by NEC, and also just recognizing that neonatal intestinal injury is relatively common and not everyone has a place to land. And so I guess I feel like the Next Society should be a bit more inclusive for families, and so that they find themselves fitting within and have a sense of belonging within the Next Society. And so I think as we're looking for better ways to define NEC and SIP, I think just keeping the family's perspective in mind and what that means for families who have one diagnosis or the other, and what that means for them in terms of finding a community and a place for them to advocate and belong and help to advance research and change. So, anything you want to add, Cristal? All right. Toby, anything you want to add before we wrap up?
No, I think I think it's great that the Next Society is inclusive of all the babies who have had other somewhat related disorders, because as you know, I mean, NEC itself is an orphan disease with we see it, but in the big scheme of things, it's small, but we need everything we can do to keep bringing it to the forefront of the NIH as a whole and the larger research community by getting these studies published in big impact journals, so other researchers learn about these small population neonatal diseases will only help us with funding and future advancement of our research agendas. So thank you, Jen, for everything you do for the disease, and to everybody else for helping promote neonatal research.
Absolutely. It's really an honor and a privilege to be able to do this work. And speaking of the work that we do, my colleague Erin has put together our impact report reflecting on what we have done during 2021 over the year. And I believe she's sharing that link in the chat box, so you can check that out. We're really proud of how far we've come at a pretty rapid pace. And I feel like the pace is definitely increasing as we continue to engage more stakeholders and momentum. So it's really exciting. And thank you all for being part of this work that we do every day. And one last polling question I have is whether you plan to make a charitable donation to a cause that you care about this holiday season. And if you do, if you might consider donating to the Next Society. We are a very small 501c3 nonprofit organization that is led by patient families who have been personally affected by the disease, who are compelled to do this work. And so if you are in a position to give this holiday season, I hope you will consider making a gift to the Next Society, and that is available on our website. So thank you especially to Cristal for sharing your beautiful son's story, and thank you to our panelists and the experts here. Thank you to Marty, Toby, Ravi, David. Thank you everyone so much for being here. Thank you to our community, and we will be in touch. See you all soon. Thanks everybody.
Thank you all.
Bye-bye. Thank you.